undergraduate at Ohio State University, did my medical school at Case Western Reserve University in Cleveland, stuck around there, did a few years of research at the Cleveland Clinic Foundation in their cardiology department, did my residency training at University Hospitals of Cleveland, and was also the chief resident of that program. I spent the last 12 years in the private practice of medicine, and in the past 12 years I've seen a whole lot of changes in my community. I practice down in Southwest Florida, a relatively underserved community. We don't have a whole lot of doctors, but what we've seen over the past several years is that our primary care private practices are being gobbled up by large corporations. So the individual small town doc that's hanging out their shingle basically is finding a hard time to survive in the local market. I'm not much of a golfer, but my brother came down to visit me last week, and we were out on the golf course, and I'm a horrible golfer, but I was terrified to see who they were going to partner me up with, because they didn't want to be embarrassed. So they partnered us up with this really adorable older couple. I mean, these people had the best personality, the best sense of humor. They were fun. We just had a blast. And we're up there on the golf course, and this lady looks across this pond. We're ready to tee off, and she sees these baby ducks, and she lives on this golf course, so she knows everything about the course. And she said, "Oh, look at these ducks. They're beautiful. They're 8 baby ducks. If you look, they all have special individual markings, and none of them are the same, and they don't look anything at all like their mother duck. And the mother duck quacks, but the babies, they squeak, but they're so adorable. But you got to be careful with the baby ducks, because out here on the golf courses in Florida, we've got alligators, and so we need to make sure there's still 8 of them, because maybe one of them could have gotten gobbled up. So when we go to the other side of the lake, you're going to have to look at them, because they're just beautiful." And she teed off and drove her ball right in the middle of the ducks, and the ducks went, they flew everywhere. And the husband got in his golf cart, and he drove around, and he said, "It's okay, dear, most of them are still alive." And it makes me think of what the healthcare reform has done to the individual primary care doctors, is with perfect good intent to provide care for everybody and to support and nourish the individual primary care doctor and to make the patient-centered medical home, it has completely destabilized the independent private practice of medicine and caused us all to fly up in the air and land in various other places. This just happens to be where I have landed. Some people ended up in large corporations, some people ended up working for hospitals, some people became hospitalists, and I became working directly for my patients. I chose to, I got tired over the time, because every Friday I would get together with my good dear friend, Dr. Stephen Shell, and we'd say, "We got to find a better way. There has to be another way to do this, because paperwork after form, after prior authorization, after step edits, we've got to fight for this test, you got to order that test." Eventually, we just became essentially working for the insurance companies. We were no longer working directly for the patient. We were just enacting sort of a cog in the wheel between the patient, trying to get them to interact with this crazy system that was in place. We thought, why is this so expensive? I mean, we're just, everyone keeps saying healthcare is expensive, it's so expensive, it's so expensive. Why is it so expensive? I'm selling brain time. I'm selling air, I'm selling nothing. I'm just giving you time. Why is that expensive? I'm not putting in a $10,000 hip orthotic, I'm not putting in a $100,000 pacemaker. I'm selling time. I've got exam table paper. I have a $1.50 hypodermic syringe that I might have to use from time to time. Why am I paying $1,000 a month for my health insurance? And at the same time my health insurance goes up 30%, I'm getting a letter from Blue Cross that my payments are going down 30%. Odd. But what it turns out is that it's the stuff outside of our office that starts to get very expensive. The hospitals, the pharmacies, the labs, medications. It's crazy what other things cost. So one day my friend Dr. Shell called me up after work, and he says, "You know, I had an interesting encounter with a patient of mine today. He owns a heating and air conditioning company. He has 10 employees, and he came up to me and said, 'Doc, all 10 of my employees come and see you. I'm paying $1,000 a month for each of my employees with a Blue Cross policy. Why don't I just pay you to take care of my employees, and then I can just get a catastrophic policy, and even if they hit their catastrophic policy every year, the amount of money I'm going to save by just paying you, I will still come out ahead at the end of the year. So he calls me up and he said, what do you think about that? What do you think about contracting directly with the businesses, directly with the employers? And I said, well, the large employers do that, the county does it. The county, they go out and they bring in a primary care clinic. And they'll say, okay, if you want to come into our primary care clinic, you can do that for free. And then we'll buy you up. We'll pay for catastrophic care if you end up in the emergency room or have to see a specialist. But in-house, it's free. Well, if you have 1,000 employees, you can do that. If you have 5 employees, you can't. Well, let's figure out a way to do that. Well, what do we need? Labs, okay? We need affordable blood work. We need affordable medications. And what other things do we need? Well, we'll probably need some physical therapy, other supportive services that primary care relies heavily on. So what we did was we created a membership-based primary care program. We can either sign up directly with small businesses or we can sign up with individuals, but it's flat fee. I think most of you probably have that flyer that I put out. It's a 2-page brochure. I do a lot of traveling, and we spend a lot of time in Washington, D.C., meeting with legislators. In fact, I think this program has been presented to members of Congress in over 300 private meetings over the past probably 3 years, over that. And when I sit down with them, I say, if you could create an ideal healthcare reform, you would have total price transparency. You would know exactly to the penny what your care costs. It would not be tied to fee for service. So there's no incentive to order extra tests. There's no incentive to bring people in when you can treat them over the phone. It would reward primary care, perhaps even have primary care have the same income, perhaps even a specialty care. It would not necessarily be tied to your employment. It would be so affordable that anybody could access the system. It wouldn't exclude for pre-existing conditions. It wouldn't discriminate based upon age. I said, and Congress passed a 2,700-page law, and so far it's written 20,000 pages of legislation and accomplished some of those things. But in the flyer you have in your hand, we've accomplished all of those things. And it's actually pretty rewarding to practice in this. So we did, in fact, build this whole system locally. So in the traditional free market, when things about, I use an example here is a 32-inch LCD TV. When an LCD TV comes into the market, it's $800. It's really expensive, but people want that TV, and the people that really want it, they're going to go out and they're going to pay for it. And then the market's going to dry up for the people that can pay for it at that price. So the price comes down a little bit. You start to get a little bit more competition in the market. Somebody else builds that, start taking it to other countries, building it cheaper, building it better. And before you know it, it's $200 at Walmart's Black Friday sale. Why doesn't that happen in medicine? This is what happens in healthcare costs. And we say, you know, we'll have 2 hospitals competing right across the street from each other, but they're competing, but the prices are fixed. Nobody's bringing the cost of care down. I use, for example, LASIK eye surgery and cataract surgery. Cataract is covered by traditional third-party insurances. Cataract surgery has been going up just like every other thing, every other cost of healthcare services. LASIK eye surgery is not covered by most insurances. It's considered elective vision correction, and it has been flat priced over the past 20 years. The quality has improved, and basically you can get a buy one, get one on Groupon now for your LASIK. They'll compete on quality. They'll send a limousine to your house. They'll drive you home. We'll have a nice cushy environment. Performed by the same exact surgeon, the same exact surgery center, by the same exact staff. But that's the difference between having a fixed price and having competition in the marketplace. So why is insurance so expensive? I mean, why is this happening? Because insurance isn't insurance. It used to be insurance, but now basically what it is it's health management. You are buying a package of prepaid healthcare services. It's all included in there. Consider what your homeowner's policy, if you owned a home, what your insurance policy would cost if it had to cover every single routine thing: mowing the lawn, painting it, vacuuming it, replacing the light bulbs, all of those things. That every time something had to be done in your house, if you filed an insurance claim, what do you think an insurance policy would cost? That's what we're asking our health insurance policies to do. When I have a cold, when I stub my toe, when I have high blood pressure, I have to get my blood drawn. These are all routine routine, just basic things that we should plan for in our lives. And so that stuff should be very affordable, but it's not. And I'll tell you, when somebody's paying $1,000 a month for a health insurance policy, when something happens, they want to use it, and they want what they're paying for. So when they twist their knee and they come into the doctor's office and they're paying $1,000 for Blue Cross, I'm paying that kind of money, I want an MRI. As opposed to when they're paying out of their pocket or if it's being applied out of their health savings account, they're a little bit more savvy stewards of their dollars. So what we've done is we've taken this very affordable primary care, again, brain time, and we've said that we have to bundle it together into a health insurance program that has to cover hospitalizations, it has to cover chemotherapy, expensive surgeries, end-of-life care. We're putting all that, and it's all got to fit into this little box that we're going to sell as a health insurance policy. What that essentially does is when you put all that stuff weighing out the system, it drastically shoots up the cost of primary care because they're now connected to one another. But if you remove all that other stuff, the primary care costs come crashing down. About 90% of what most patients need we can accomplish at the level of primary care physician. And that's where we created Epiphany Health. So what it does is it carves out the routine care from the catastrophic care. We charge a flat rate monthly membership fee. You'll be probably surprised to see what our fees are. Some of it's in that book, but we've actually even come down with some better pricing since that. And now what that does is it allows catastrophic insurance to be true insurance again. It allows you to use true actuarial figures and real market to determine what the price of healthcare can be. And so you've now fixed the cost of all your routine stuff. So there's no surprises whatsoever. We're not fee for service. We know to the penny what the care for our patients are going to cost. We have created a network of pharmacies that contract with us. We've created contracting with 2 national labs, imaging centers, physical therapists. We have ambulatory surgery centers under contract. We have a whole team of private physicians that are now contracting with us to take care of patients basically for cash. So this is what we include. I don't know if that is actually in the brochure, but we include 1 annual physical for the membership fee, up to 25 office visits per year. We don't charge for anything we do in the office. If it can be done in our office, we don't charge a penny for it. There's no co-pays, there's no deductibles. The PAP test is included for women, the prostate cancer screening test for men. We include a mammogram because we're contracted again with imaging centers, so that's no additional cost in there. We do colorectal cancer screenings. We include the typical blood work that somebody needs. So if you're diabetic, have high blood pressure, heart disease, high cholesterol, we just bundle all that stuff in, and it's all included in there if you need it. If you need an EKG, we'll do it. We include your flu shots and your routine vaccinations. We don't, again, charge any co-payments for anything we do. If you need a cortisone injection, we do it. If you need a Holter monitor, we do it. What's excluded? We don't exclude for pre-existing conditions. We don't charge extra if you're sick. In fact, the sicker you are, the more you benefit from our program. 2 exceptions. We don't treat chronic pain. We don't prescribe chronic narcotics or controlled substances. So examples, if somebody were to come into our office and they were a self-pay patient, we would typically charge $150 for an injection that's included. We do skin surgeries, like to take off skin cancers. We don't charge the AMSA for it, normally in the hundreds of dollars. We can drain abscesses, $300, we include that. For our partners in the community, we have cardiology under contract, our stress tests, which are pretty high tech, you can get for $500. CAT scans, $200. We have contracts for colonoscopy, $1,000. People say, that's a lot of money. Well, colonoscopies are typically $3,000 to $5,000 if you're a self-pay patient. You probably need one every 10 years. Okay, so $1,000 every 10 years compared to $1,000 a month for your health insurance policy. If you came out of your pocket, you'd actually still be coming out way ahead. So a patient comes in and says, oh, I'm having horrible chest pain. I need a chest x-ray. Or I say, you need a chest x-ray. I say, I can't afford it. I said, it's $22. Can you afford that? Actually, yeah, I think I can afford $22. That's not a bad price for a chest x-ray. This is fun. This is an actual bill of a patient of mine that was on Medicare that went to the emergency room for abdominal pain. I'm going to go to another slide that summarizes it, but these are the numbers that they charge for this ER visit. Basically, the patient came in with abdominal pain, got a CAT scan, a bunch of blood work, urinalysis, saw the doctor. you'll see here that this bill, and this is a real bill, I showed you the copy of it, was $19,723 for about an 8-hour emergency room visit. If he had no health insurance, this is what he's on the hook for. Okay? Let's just say that same patient, instead of going to the emergency room, they were signed up with our program. You know, that person said he didn't have insurance, went to the ER. That's the bill that they're on the hook for. If they came to my office under Epiphany Health, the exact same person, the exact same problem, I ordered the exact same tests, and to be honest with you, we probably did the stuff in the exact same facility because we're contracted with them. That would be their cost. Those who can't read, that says $278, and it just so happens that's a 98.6% reduction in the cost of care to this person that didn't have health insurance. Now, what do we charge for that? We charge $80 a month per person. They can add a domestic partner or spouse for $150 for the parent, or $175 for the entire family, no matter how many children you have. That's cheaper than most people pay for their cell phones. Certainly less than they pay for their cable television. So let's look at that compared to what we actually charge for our services compared to, say, if somebody signed a traditional PPO insurance contract. A family of 4 under our program is $175 per month. Now, as of last year, a traditional PPO insurance policy for a family of 4 is about $1,800. So if they just signed up for our program alone, they got nothing else, they'd save $17,000 a year. Now, if you look at this graph here, this number at the bottom here, well, this number at the top here is, again, over 10 years, the cost of a traditional PPO plan for a family of 4. This number up here would actually be $220,000 if it works properly. This number down here is the amount of money that that same exact family would pay if they signed up for our health care program and got a $10,000 catastrophic high deductible health plan. Okay? So they're paying $51,000. The savings over 10 years is $168,340 over 10 years. And somebody says, $10,000, that's a lot of money. Who's going to come up with $10,000? Well, they're already paying this, okay? So this is just the money that they saved. So let's just say, for argument's sake, this was the sickest family you've ever seen, and they hit that $10,000 deductible every single year for 10 years. That would be take $100,000 off of that. They're still almost $70,000 ahead by paying for their own healthcare services and not relying on the insurance. Now let's take that same heating and air conditioning guy that came to my partner and said, okay, how much money is he going to save over 10 years? If he had 10 employees and their families, and he's paying for it all, his savings was $1.6 million over 10 years. This is the nicest guy in the world. He says, you know what, I'm going to pay for the deductible for every single one of my employees to $10,000 if they get into trouble. And now their employees are not coming a penny out of their pocket for their health care because all their primary care needs are met. And now their employers covered their $10,000 deductible, so they're not coming a penny out of care or out of pocket. Take $1 million off of that. That employer saves $700,000 over 10 years. And the patients, his employees didn't pay a penny for health care. So how does that work for us financially? How can you sell it for that cheap? How can you include all that stuff? Well, we have good contracts. Those labs that we promised cost us $30. The mammograms, we negotiated a rate of $25 per mammogram. We pay $6 for our flu vaccine. That PAP test, we're contracted to read that at $28. So our promises to these patients, we're about $80 for a month of care, or for all the stuff we promised. And the rest is just time and, again, paper and staffing. So that's about 50% overhead is what a typical primary care practice would run. We're probably more in the range of 30%, but for argument's sake, we say 50%. So basically, in the first month, we're at a break even. If the patient comes in, they pay for us for 1 month, and they fall off the face of the earth. They get everything we promised them, and they never show up. We've broken even. The rest of the 11 months are now profit for us. We've established what we feel is an appropriate profit margin for us. And so if we signed up 500 patients, basically our profit is $880, or our take is $880 a year after those expenses. That's a take of $440,000 a year. We take off the 50% overhead, which is not really 50%, but we'll say it's 50%. That's $220,000 for a practice of 500 patients per year take home. That's not bad. Now you throw in the family members, and you now have basically an income that's comparable to a lot of specialists around there, doing what you want, working for the patient, no longer having to fight the insurance companies hassle over everything. You are now, when you walk into that exam room with the patient, you are the only two people in the room. You don't have the insurers in the room, you don't have the legislators in the room. It is a pure, beautiful relationship between the physician and the patient, and nobody else is spoiling that. When you make decisions to order tests, you do it because it's the right thing to do. You do it because it's the affordable thing to do, and you do it in the order that it's correct to do things. And some people say, well, this is a concierge practice. That's all you're trying to do is you're kicking everybody else out. Well, the difference between our program and a lot of things like it in the country is we've developed a hybrid model where you can add this to any practice in the country. You can start seeing patients in this program tomorrow. We can establish and install this thing in any practice in the country tomorrow to make this happen. And nobody is kicked out of care. So if you look at this on a national level, what does this look like? The Affordable Care Act, the health care reform. Let me talk just a second about that. The policies that are being sold under the Affordable Care Act, they're bronze policies, they're most affordable policy. That policy is going to have about a $3,500 deductible. After you hit your $3,500 deductible, you will then be responsible for 30% of all your health care costs until an individual gets to $6,700 of annual expenses. Okay? So even if you sign up for one of these Affordable Health Care Plan or Affordable Health Care Act plans, you still need to be a smart consumer of health care resources because you are still paying your way into the system. You just now have a catastrophic safety net, which is great, but this program is still relevant in a post-Affordable Care Act world. So anyway, 32 million people are expected to gain coverage, not care, coverage, under the Affordable Care Act. Many of those are going to be included in the Medicaid expansion in the states that expanded Medicaid. I can tell you that I have lots of Medicaid patients in my practice that are signed up for the Epiphany Health program because the closest doctor to me that accepts new adult Medicaid patients is about an hour and a half away. Under the program, it's already assumed that 26 million people will still remain uninsured. So we've got 58 million people that we're trying to fix. So we're going to basically fix half of them, the other half will remain uninsured. And the projection to do that is $1.8 trillion over 10 years. That's the cost projections. Originally, when it was passed, it was $800 billion, but since it's passed, it's now gone up to $1.8 trillion. Let's say instead of that, we allow all 58 million people that have no health insurance to sign up for the Epiphany Health or Direct Primary Care Program. We let every doctor in the country do this. Our 10-year costs on that, now again, 100% people now have care, as opposed to 50% that have coverage. We have 100% that have access to actual care. Our cost is $556 billion. The savings on that is $1.2 trillion, and we've covered everybody. So with that $1.2 trillion, you can very easily create a Medicare for all safety net. You can create all sorts of neat things if you just open it up to some free market principles, allow market forces to work. When I presented this to a conference in Washington, the first question when we opened up the questions, a fellow said, well, you're charging $83 a month. What happens when the doctor next door to you charges $60 a month? And I said, well, if the first question from the audience is, what's going to happen when the cost of health care comes down? I said, that conversation has never been had in the United States before, so we've accomplished something if that's your first question. So the second of all, either I'm going to have to lower my price, or I'm going to have to justify why I'm $20 a month more expensive than this person. Because if I don't, my patients are going to go over there. We may find out that I'm too expensive. Maybe I do a better job. That's a built-in pay for performance. I do a better job, I get more patients, I can charge a little bit more money for it. But the market will determine what the value of my services are. I don't know if my price is right because I have no competition. My price may be too low. In fact, I've been told my price is too low. But we've been doing this since 2009. We have several hundred patients enrolled. Just recently, our county health department lost its funding for primary care. And so they closed the primary care program, county program. And they sent out a letter to all their patients, and they said, we're sorry we don't have the funding to carry on the program anymore, but we know you need access to health care. And they gave two options for these folks to go to. One was the federally qualified, federally funded health centers, and the other one was Epiphany Health. I can tell you the federally qualified health center was furious that they included a private corporation as an option for these folks to go to. And their protest was duly noted. But our phones rang off the hook. We signed people up left and right. And these people that were on public support and not happy with it are now paying their own way. They're not getting the subsidized care anymore. I have folks on Medicaid that are in my program because none of the doctors take Medicaid. It pays 60% of Medicare, which pays 60% of what a commercial insurance policy pays. So we believe we've built the better mousetrap. We're excited about it. We intend to expand this model, and I am one of the few folks, at least in the independent practice of medicine, that is really excited for the future of what independent practice of primary care is. And I can tell you in my community, in the last 3 years, my partner and I are the only two doctors left to remain in the private practice of medicine. Every single other practice in the community is sold for the last two standing. So we're pretty proud of that. This is the only reason that we're in that position, and I'm happy to take any questions you have. Yes?
What leveraging power did you have to negotiate those prices?
The question was, what leveraging power did we have to negotiate those prices? Zero. Those prices were set by the people that did that. So what we did was, we didn't twist any arms. I twisted one arm. I told my radiologist friend that I needed a $25 mammogram. That was the only price I set. Everything else, I went to these providers and said, if I send you a patient and they agree to pay you at the time of service, you don't have to bill them, you don't have to collect, you don't have to spend 6 months haggling with insurance companies, you don't have to do prior authorizations, step edits, fill out forms, wait on the phone. What can you sell that price for? Just name your price, give me your top 10 services, and tell me what your price is. I don't care what it is, just let me know what it is. And by the way, give me a 90-day notice if you decide to change it. They named their own prices. There was no twisting of arms, they set those prices. Wow. I have GI under contract, cardiology, rheumatology, nephrology, general surgery, orthopedics, and ambulatory surgery center. They're banging on our door asking to sign up. We're not going on for it. There was a hand back there. Yes, in the back.
Why is there the exception for chronic pain?
As you probably know, Florida has a bit of a reputation of having pill mills. We want to make sure that we're not exchanging cash for narcotics. So that's the only reason. Yes, in front.
So with the leverage question, you're basically using the tediousness and the burdensomeness and the bureaucracy of the current system as your leverage.
Exactly.
That's amazing. What is the way that you help other practices start your model? Do you charge for sending someone to come back? Do you do it over the phone? Do you do it through Skype? And have you had any success in some place like New Jersey with all its interesting quirks?
I can tell you the expansion right now is a relatively new thing for us, okay?
Okay.
Because we wanted to make sure that worked and that we could prove that we could survive. And we also wanted to see what happened when the Affordable Care Act officially went live. We wanted to make sure we would survive that transition. So we pulled back on actually expansion, but we designed it so that basically I could send contracts down to, let's say you go to practice in New Jersey. Basically what would happen is your patient, I would sign a contract, I created a company, Epiphany Health. You would contract with Epiphany Health just like it was a health insurer. Your patient signed a contract basically with Epiphany Health, and basically all the money goes from Epiphany Health to directly into your bank account. It's a monthly draw. It's all automatic. There's no billing. There's no collections. We pull directly from patients' banking accounts. So basically just a matter of signing a contract.
Okay.
We still got the details, but we probably would take a little bit off, like 10% administrative fee for doing that. We're also looking into franchising. Right now, we're working with a company out of North Carolina. We've created the first wraparound direct primary care insurance platform that doesn't duplicate any services. We rent the local insurance networks. We can work with a small business up to starting at 2 employees And what it essentially does is allows them to pool risk with other small businesses across the country, allows them to self-insure, and then we've thrown out a catastrophic safety net with a nationwide policy. So we're allowing small businesses to self-insure. Their rates look like we're coming in about 10 to 30% of our traditional insurance plan. Yes?
So you mentioned the patients who went to emergency room for your medical care. You said you get this treatment cheaper if you have your plan. How does that, can you explain a little more about how that would work in terms of getting all the services that you have on and in like the same length of time frame?
Yeah. The question was, basically how does that work? The question, how do you deal with emergencies like that?
Well, you said like if you had, like, yeah, how do you do it?
Okay. A lot of that's really on sort of how you manage your practice. I run an open access platform on my practice, so basically an hour I got blocked out before lunch for same-day appointments, an hour at the end of the day I got blocked out for same-day appointments. And so if you call me at 8 o'clock, I can always see you within 3 hours of your visit or your call. If you call me in the afternoon, I can see you within 3 hours. But we always can get you in within, the most you'd have to wait is 3 hours to get in to see me. You'd wait in the emergency room for that anyway. We can get right into the imaging centers. We can get this stuff real time. There's no reason for folks for that sort of problem to go to the emergency room. If you can't wait 3 hours, you belong in the emergency room. We encourage our folks to have catastrophic coverage. Under the new Affordable Care Act, they can buy high deductible health plans. They can't be turned down. So these folks will have insurance policies if they need them. But we create predictability in the day-to-day care for these folks. And keep them out of the emergency room.
So how, I mean, to do labs like the ER would do, how long? You said you can get imaging within an hour. Labs?
About an hour.
Okay, that's actually faster than some ERs. I'm
Yeah,
on my
it's
ER rotation
on
right
par.
now. Okay.
It's on par with it, but we can staff labs.
Okay, and how about medications? Do you have a plan with pharmacies or with drug
We're
companies?
contracted. The question is, what do we do about medications? We have contracts with 4 mom-and-pop pharmacies. We've got a pharmacy right on our doorstep. And so our contract is, well, you can do a lot with the $4 Walmart plan.
Right.
The drugs that are on there, you can pretty much get everybody, almost everybody with a good generic plan. Our contracts for name brand pharmaceuticals is wholesale cost plus 2%. There's 2% markup on those for our pharmacies. If you guys are doing clinical medicine, there's an app for your iPhones that's called GoodRx. You might want to look at it, GoodRx. And basically what that does is it will give you discount codes, coupon codes for medications, and you can probably save 60 to 75% off of brand name medications, or even with generics with that. But basically what it is it's a code. You give the code to the pharmacist as if you had an insurance card. And I can tell you I've used it myself. Took my wife a prescription for Imitrex to the pharmacy. We have a high deductible health plan, and so we pay cash for all of our own health care. And I had a prescription for 9 Imitrex, which was for migraines. And the pharmacist said $140. And I gave them the code, and they brought it down to $14.
Wow.
Yeah. There's another group called Atlas MD, which is doing different than what Dr. Gross is doing. But they, as a physician's office, you can dispense medicines. So pharmacies can dispense medicines, so can physicians. So what they do is wholesale purchase for their patients with 0 markup, and are able to provide all sorts of medications at a 90% discount to what they'd be paying at the pharmacy. And so there's a whole variety of things that can be done once you start thinking outside the box of how do we interact with people. I mean, what he's been able to negotiate with these diagnostic places is fabulous. I mean, a number of them are small places, some of them are big places, but as you get more central planning and control, you get rid of the small guy who is really the one that is going to be the competing to bring down the costs. And by allowing this family practice to directly work with smaller imaging areas, smaller diagnostic areas, they're trying to survive just the way the independent physician is trying to survive. So they're looking at how do I maximize value and lower the cost to get this to work, just to be able to survive themselves as well within the new system. So that's part of the solution.
I have exceeded my allotted time, so I'm going to be around if anybody has any questions. I thank you for your attention so early in the morning, and enjoy the rest of your conference.